progressive, the more that that arthritic joint moves, the more that that cartilage is going to become worn down. And so we can see, continued difficulty and pain with ambulation, increased inflammation, and increased pressures under adjacent joints. Treatment, everything from conservative. We've talked a lot about shoes, limiting motion, orthotics. I won't hammer that home anymore. Different types of anti-inflammatories, different types of injections. Obviously, those are not necessarily treating the condition. We're not putting that cartilage back. But for a lot of people, a routine kind of, every 3 to 4 months injection is enough to kind of delay or avoid that conversation about surgery. And for some people, surgery just is not the right option. When we do talk about surgery for arthritic conditions, typically we are talking about either a joint preserving procedure as far as joint replacement, or a joint destructive procedure, limiting that motion, limiting the pain, therefore, through a fusion type procedure. Other age-related issues, and we'll hit on some of these here in a little bit, but decreased healing capabilities, decreased blood flow, venous disease, leg swelling, diabetes, gout, all of these things becoming more prominent as we age. So jumping into a conversation more so about that vascular disease, peripheral arterial disease is just a narrowing of the arteries due to plaque formation. Basically, that things become narrower and less blood flow, less of the nutrients and oxygen are making it to the tissues. The buildup of when arteries, I'm getting redundant here, okay. Also known as PAD, PVD, peripheral vascular disease, otherwise poor circulation. Peripheral arterial disease affects approximately 8 to 12 million Americans. 1 in every 5 people over the age of 70 has some decreased blood flow to their lower extremity. Peripheral arterial disease and diabetes are the leading cause of non-traumatic lower extremity amputations, also just kind of recurrent wounds, delayed healing, infections, all of those things being related to that decrease in blood flow and decrease in healing capability. There are simple blood pressure tests that are able to look at this. We call this an ankle brachial index, or an ABI. That's something that typically we refer you to the hospital to have performed, but that's a good jumping off point to evaluate for these. And if it does come up, typically we're talking about, a number of different avenues for treating that, typically involving a vascular surgeon at that point. The chance of having peripheral arterial disease does increase as you age. People over age 50 have a higher risk. Other behaviors and conditions that can increase that risk, certainly smoking, diabetes, those types of things are causing that stenosis within the blood vessels. High blood pressure also contributes. Family history, any history of prior stroke can certainly cause or be indicative of, potentially some artery disease, whether in the lower extremity or in the coronary vessels. Are you at risk? We talked about abnormal blood cholesterol levels. If you're being treated for cholesterol, if you're on a statin, it's always a good idea to be screened for this. African Americans do tend to have a higher prevalence of this, and so that's always something we pay extra attention to. Any history of heart disease, heart attack, or stroke, if it's happening within the vessels in the heart, chances are it's happening throughout the body, and we want to be aware of that. Different warning signs, things to look for that would clue you in that maybe it is time to have that talk with your physician. Cramps, tiredness, or pain in your legs, thighs, or buttocks that almost always happens when you are walking but goes away with rest. We call that intermittent claudication. Similarly, signs of increased Are we still? Oh, we're there. Okay, never mind. Anytime you are having that same cramping, that same pain that could be waking you up or preventing you from going to sleep, more so in the calf muscles, anywhere else, those are issues that disease is becoming progressively worse. Any kinds of wounds, ulcers, things that are slow to heal on the lower extremity are things we want to pay attention to. Is it serious? We already talked about kind of the prevalence here, but this is something that, like I said, if it's happening in one part of the body, we assume until proven otherwise that we're going to see that throughout the blood flow in the rest of the body. And like I said, common linkage to heart attack, stroke, all of the other vascular concerns we have. We'll skip ahead just a little bit. Sports medicine, I know that this is a topic that was requested. You know, the benefits of exercise, obviously, cardiovascular health, mental health, overall health, and disease prevention, as well as management of other diseases. You know, staying active, staying on an exercise regimen is going to help to stave off a lot of the concerns we've talked about. You know, additionally, diabetes, obesity. Um, I'm not sure if this is actually correct. I stole this from another source, but every minute of walking adds 2 minutes to your life. Don't quote me on that. It is never too early or late to make exercise a healthy habit in your life. And that studies do show that as you age, the more active you are able to stay, the less health issues that we see in that older age. And that physical inactivity does contribute to preventable death every year in the United States. Talking about the anatomy of the foot, there are 26 bones and 33 joints, over 100 ligaments in the foot. And so it really is this really intricate machine. And all it takes is one thing to be out of sync, you know, everything having its kind of yin and yang, that a strain here or arthritis in this joint is going to affect other parts of your foot. And so obviously the foot structure and function impacts the ankles, the knees, the hips, the back, everything kind of functions up and down that kinetic chain. Just a closer look at the skeleton, as well as all the muscles and tendons coming from both the leg as well as the foot. Impact factors. This is a really important slide that I like to highlight. When you are walking, you know, your regular body weight, you're putting about 1.5 times that stress, that body weight through your feet just with every time that you are getting to that push off phase of gait. That increases quite a bit with running and jogging. That increases to about 3 to 4 times that same impact force. And any kind of impact, including running, jumping, really strenuous exercise, up to about 8 times that body weight force on the feet. Preventing these types of injuries that we can see with exercise, you know, proper conditioning is really important. I talk to patients almost every single day about stretching, particularly kind of the calf muscles or something that we see like to tighten up as you age. And so stretching those posterior calf muscles, taking the time both before and after exercises is very important. Warming up, like I said, talking to your doctor if you have concerns about starting a new exercise regimen or you want to start a new activity and you're thinking about picking up a new hobby, just to kind of figure out how to ease into that, not trying to run that marathon when you haven't taken that first jogging step for, you know, years. Uh, Proper training. We talk about cross training, kind of cardiovascular. We want to not only focus just on the lower extremities, but kind of the body as a whole is very important, and then gradually kind of increasing levels of activity like we talked about. Additionally, proper shoe gear. We've talked a little bit about this with the calluses and everything else, but just making sure that you are wearing good supportive shoes, good socks, making sure that we're not walking barefoot, that we're not in our shoes without socks, like I talked about. It's very easy to develop injuries just from the friction, from the pressures that can result inside of shoes. And then we've already kind of hammered home the idea of orthotics and inserts. And so shoe selection, you know, really briefly here, everybody's a little bit different. My go is always to tell people, ideally, you know, try on a lot of shoes and try them on inside the house or inside the store, walk around in them a little bit just to see how they are going to fit, because it is hard to figure out kind of within 10-15 seconds if that shoe is going to work for you, and what works for one person does not always work for another. Some general recommendations: typically you want about one thumbnail length at the end of your longest toe. So typically the first or the second toe, just having a little bit of extra room there. You want to fit to your larger foot. You know, it sounds silly, but over about 50% of people do have one foot that tends to be just a little bit larger than the other. and fitting later in the day. The feet, as we're up, as we're moving around, as gravity is having a impact on our feet, they do tend to swell a little bit, and it's important to accommodate that in the shoe. If you're sliding on a shoe and it feels great, nice and snug in the morning, chances are by the end of the day it's going to start causing some issues. And then same idea with or without orthotics and insoles. A lot of times when we do talk about insoles, I give recommendations, or we're talking about custom inserts, anything like that. By the time we get those down into the shoe, that shoe is fitting a lot differently, and we can be running into issues with where the laces are hitting, where different seams and things on the shoe are hitting. Other common, skin issues, we talked about the importance of good fitting shoes. Socks. There we go. Okay. Blisters, athlete's foot, warts, excessive moisture and sweating. Those are all things that we can see related to the skin. Soft tissue injuries, certainly the ankle sprains, muscle strains, tendonitis, plantar fasciitis, toenail injuries, runner's knee, shin splints. Bone injuries, we talked a little bit about the stress fractures, traumatic fractures, kind of less related to sports injury, but if you're lifting weights and you drop that weight on your foot, chances are you could pick up an injury that way. Treatment of injuries, prevention really is key for these types of things. And so we want to protect the foot. If you do feel like something is aggravated, something new is happening, using that as a reason to slow yourself down, take that rest. If you need to back off that activity, find a different way to do that activity or to get that exercise. Short term, that is a good outcome. Long term, typically worthwhile to get in and see somebody about that. Lastly, kind of the last topic, and again, this is where we can get really wordy, but we will talk just kind of briefly here about diabetes, because it is something that we see quite a bit in our office, and a very preventable disease, as well as preventable outcomes when we talk about the different ways we can see diabetes affect the feet. So nearly 37.3 million people, and I believe these stats are about 2 years old, or 11% of the US population have diabetes. About 29 million people have been diagnosed, leaving about 8 to 9 million people walking around not knowing that they are diabetic, that they are at increased risk for some concerning sequelae. Pre-diabetes, about 96 million individuals in the US, or 38% of the adult US population, is considered pre-diabetic. That's 48.8% of individuals 65 years and older. And so we do see that prevalence increases, both pre-diabetes as well as diabetes, as we age. These are numbers that we are constantly seeing on the rise. And you can see, generally, we can see some demographic shifts within the U.S. Typically, Southeast, we see kind of the highest concentration of diabetes, but realistically, in recent years, this data is about 6 years old. As we follow this, everybody kind of quickly catching up, and so we see this, especially throughout the Midwest, rapidly on the rise. Discharge data in 2018. So people who were hospitalized with a diagnosis of diabetes, we see that 1.87 million of these discharge or diabetic patients who were hospitalized with concerns for major cardiovascular diseases. Diabetes and cardiovascular diseases very, very closely linked. That includes reasons for heart disease, stroke, heart attack, all of those pathologies. 154,000 diabetic patients were admitted to the hospital for a lower extremity amputation. Typically, this number is actually very underreported because a lot of these are being performed in the outpatient setting, not necessarily within the hospital systems themselves. And 226,000 for hyperglycemic crisis, basically high blood sugar and the effects that can have on mentation, as well as just your overall health. So what is diabetes? Diabetes is a disease that occurs when the pancreas cannot produce insulin. That's considered our type 1 diabetes previously, kind of juvenile diabetes, or that the body becomes desensitized to the insulin that you are creating, and as such cannot effectively use that insulin to bring your blood sugar down, all leading to kind of the same conclusion that as you ingest sugar, your body is unable to deal with that appropriately. Like I said, type 1 diabetes, kind of that pancreatic underproduction of insulin. Insulin is important for the blood sugar to actually enter cells to be used during metabolism. Type 2 diabetes being kind of more so your acquired diabetes, acquired insulin resistance. Typically, we see this occurring over the course of years. And so when we talk about patients who are considered pre diabetic, that also falls into kind of this type 2 diabetes. And then lastly, kind of the gestational diabetes, typically temporary diabetes that resolves typically very shortly after gestation, pregnancy. Risk factors for developing diabetes. Ethnicity does play a large factor in developing diabetes. There's a lot of socioeconomic factors as well as potential genetic factors that go into this. We see the highest rates of diabetes within African Americans, American Indians, Asian American, Pacific Islander, and Hispanic American individuals. Overweight or obesity, those are predisposing conditions, as well as family history of diabetes or gestational diabetes. Diabetes in African Americans, we talked about 3.7 million, or nearly 15% of all African Americans aged 20 or older have diabetes. 25% of African Americans between the age of 65 and 74 are affected, and it is the fourth leading cause of death among African Americans. Other risk factors that we see for developing diabetes, we talked about obesity. About 90% of those diagnosed with type 2 diabetes are overweight or considered obese as far as the BMI is concerned. Tobacco use, there's a positive correlation between tobacco use and developing diabetes. Inactivity, and inactivity being described or defined as less than 10 minutes per week of moderate or vigorous activity. High blood pressure as well as high cholesterol being additional risk factors. Diabetes really does affect many parts of the body. I've heard people talk about this as kind of a metabolic cancer, and I think that in some ways that can be very accurate. We see the effects of this on the skin, on the feet, on the eyes, blood vessels, cardiovascular, your heart, the nerves, overall just all of the ways that the body kind of maintains its homeostasis. We see that diabetes kind of drives a wedge in each of those processes. Multi-specialty care is really important when we talk about treating diabetes. Typically that starts with your primary care doctor, your internist, but a lot of times includes an endocrinologist, podiatry for your feet, ophthalmology for your eyes, vascular surgeon, nutritionist, all of these people kind of providing their own particular insights to focus more so on the prevention as well as progression of some of the complications we could see. Focusing more so on the foot and ankle, proper foot care is essential. Taking proper care of your feet involves just adopting simple routines. We talked about checking your shoes, making sure that we are doing routine foot screens, taking action early as opposed to waiting to see how things go if symptoms do arise. Like we talked about, diabetes affecting both the circulation. We hinted a little bit earlier as neuropathy. Neuropathy basically arising from the effects of that high blood sugar on the insulation, the myelin sheath around the nerves, and now these nerves are not able to function. They're not able to send those signals. A lot of times they're sending confusing signals to your brain. And can result in complete numbness, obviously putting you at a lot of risks in regards to the feet. We're going to skip ahead just a little bit because I do want to leave time. Different things we do to test for some of that neuropathy. There are vibrational tests, monofilament screening tests. Some of you may have had this performed at your doctor. It's, commonly a part of even just a routine physical examination at your doctor. And then there are kind of nerve conduction velocity testing that can be done to evaluate kind of at what level this is not functioning appropriately. Different foot problems that we see developing with diabetes, certainly sores and ulcers that are slow to heal or do not heal, that can lead to infection. It can lead to abscess, amputation. Unfortunately, it is something that we deal with a lot within the realm of kind of podiatric diabetic care. Corns and calluses, same idea. These can become pressure sores. These can become cracks in the skin, fissures that can cause a lot of issues. Ingrown toenails, fungal infections, hammer toes, bunions, any foot deformity potentially being more at risk due to that decreased sensation as well as decreased blood flow. Charcot foot is another. Here's just some gnarly pictures we can look at, different athletes' foot infections, toenail infections, calluses, pressure sores underneath pressure weight-bearing areas, ingrown toenails, cellulitis, abscess, different types of deformities that we've kind of talked and defined earlier as far as hammer toes, claw toes. Certainly these are progressive. They can lead to overlapping and underlapping, a lot of extra pressure on different areas. We talked a little bit about Charcot foot. This is a really unique, relatively rare complication of diabetes, but in the insensate foot, unfortunately, little microfractures can occur, and that bone starts to basically demineralize. It starts to resorb, starts to collapse into what we consider a rocker bottom foot that is at all sorts of risk for breakdown, wounds, and amputation. So different warning signs for the feet: redness, numbing, swelling, any changes in temperature, whether that be hot, that might indicate an infection, or cold to the touch, discoloration, inflammation. We hit a little bit on ulcers. We talked a little bit about the infections. Up to 25% of people with diabetes will experience an ulcer or a wound at some point in their lives. Amputation rates can be reduced by 45 to 85% with kind of your regular routine diabetic foot care, kind of preventative type appointments. I think I'm going to stop right about here so we can leave about 15 minutes or so for questions. I do want to, just say that particularly of interest to, the audience, a lot of these services are very well covered by Medicare, especially in light of pain, difficulty caring for your feet, any kind of vascular disease or diabetes. Medicare does cover kind of these routine, regular visits to come see us. Those are both preventative. We do a thorough exam, but also addressing anything we may run into. There are some nuances there as well. Private insurers typically also cover that well for kind of the vascular concerns as well as diabetes. And so really, if you do have any concerns, anything you've been kind of eyeing and wondering if it's getting worse, always worthwhile to stop in to get some of those answers and to talk about how we can prevent that from becoming a bigger issue. Because by the time things make it into the office, a lot of times, we are missing that window of full prevention, and we're starting to talk about, okay, how do we treat this? How do we try to unwind this, kind of get ourselves back to a good baseline? So that said, I am happy to take any questions.
Okay, we're going to get to questions in a second. They have to go through the microphone, or the people at home can't hear that. And I also want to take some questions that came in online as well. So I have one question online. I'm going to ask that, and then I'm going to pass the microphone to Allison, and she'll bring it around to anybody who has questions here. So we can do that. The one question that came in so far online is, you talked about the blood pressure in the lower extremities and the blood pressure test. Is that a primary care physician exam, or
Right. So typically that is not something that is going to be performed at your primary care. They have to have kind of the special instrumentation. We also don't perform that in our office. Typically, if we do have those vascular concerns, we are sending people to the LMH health system with an order to schedule time for that testing. That testing is basically looking at kind of the bilateral lower extremities, blood pressures as they come down the leg into the foot, even into the toes, and looking at those segmental pressures. If there's any discrepancy between those, kind of kicks out a generated number in that sense, and can indicate whether additional testing is necessary.
When should we consider having that done? I mean, what kind of,
So one kind of entry level testing is just whether it is with your podiatrist or with your primary care doctor, having them feel for your pulses. There are pulses both on the top of the foot called the dorsalis pedis artery, as well as on the inside of the ankle called your tibial artery. Both of those, if we notice any kind of weakness, if we're noticing any of the trophic kind of changes in the skin, decreased texture, turgor of that skin, certainly if you are having any of those symptoms of intermittent claudication, typically that shows up as somebody walking into the office and saying, I feel like I'm not able to be active as I want to be. Very predictably, I walk, a half block or a full block, and I feel like my feet are going, or my calves, my legs are tired. They're swollen. They're going to explode, and so I need to get off my feet and take that rest before I can get up and moving again. Um,
as far as toe fungus,
Mhm.
how effective are products like the ointments? And also I've heard Vicks VapoRub.
uh-huh.
And if they are effective, how effective would they be if you try to apply them through nail polish?
Good questions. I think I can knock both of those out with one answer in saying that unfortunately they are not very effective. I tell a lot of patients when we have these conversations quite a bit. Unfortunately, typically by the time most people are concerned about it, and we're seeing a lot of the thickness, the discoloration, typically our success rates at treating that are just not great. There are not a lot of good options. Now, certainly some of the products out there, the different topicals as well as the Vicks VapoRub, those can work to we can stop on their own at home. A lot of times it is while you are using that, maybe you are seeing some of that discoloration improve. But then when you stop using that, these toenail fungus are very resilient. They're very good at kind of evading these antifungal medications, especially the topical medications. And so those tend to recur very quickly. Usually within about 3 to 6 months, most patients are going to find themselves kind of back where they started. There are some prescription strength products that work well, or at least better. Unfortunately, they're not well covered by insurance. Most insurance companies will see that as kind of a cosmetic thing, and so a lot of times those are a cash pay service. If you send in some of these uh, advertised products that you might see on TV or online, and I send a prescription to your local pharmacy, chances are, depending on which product it is, it can be upwards of about a supply of that. There are some pharmacies that have negotiated in the area cash pay options for that, and so we can do that. Vicks VapoRub, really good option just to penetrate that toenail, soften things. Um, it does work typically through toenail polish well. It is something that more so just because of the oil in there, because of that ointment, because of the eucalyptus in there, all of that just kind of penetrating. There's one study out there that shows that maybe in about 0.01% of people, or sorry, 0.1%, 1/10 of a percent of people that might actually treat the fungus. The flip side of that then becomes a discussion about oral antifungals. And oral antifungals, such as terbinafine or Lamisil being the brand name, can be a little bit more effective. Realistically, by the time we are dealing with toenails, kind of like pictures we've shown, the chances of getting that back to a regular toenail are pretty darn slim, usually less than 5% cure rate over the course of kind of a 12-month period. And even in patients who do see some improvement, maybe not that full cure, usually at about 12 months, there's about a 50% recurrence. And so ideally keeping your feet dry, alternating shoes kind of every other day. Sorry, the question was just about prevention of toenail fungus. Keeping feet dry, if you are somebody who sweats, making sure that you are changing your socks kind of throughout the day. There are different types of moisture wicking products that you can put inside of your shoes, different sprays and powders and things. But I always recommend, especially in patients who are, wearing closed-toed shoes every day, make sure that you are alternating, even if your shoe doesn't feel moist or it doesn't feel damp when you're putting your foot in there. There's a lot of that humidity that gets kind of stored up inside of that shoe, and we want to give that proper time to air out. And sometimes that's more than just kind of an overnight before you get up and go in the morning.
You mentioned socks were important.
Yes.
And so is there a particular kind of sock that one should look for when they're buying socks?
Not necessarily. The main thing I would caution against is anything kind of like the really, low profile footy socks, especially if you have a shoe where the side comes up beyond that. That can cause a lot of irritation, a lot of rubbing. Thicker typically is a little bit better. Now, there is kind of an upper limit to that as well. Ideally, kind of the cotton and wool being preferred over a lot of what we find now with the different synthetics and the polyester, a lot of elastic. For diabetic patients in particular, I definitely would recommend diabetic socks. Those are specifically designed to decrease pressure, decrease friction against the skin, and that can be a really, really good. It's a woven kind of fully organic material, cotton, wool, depending on the brand. And those you can typically find, over the counter at a Walmart or a Walgreens. You can get those on Amazon, but the diabetic socks being a good option to decrease any kind of shear force inside of a shoe. Yes.
I was wondering about edema in the
Yes.
feet and ankles,
Mhm.
causes and how to prevent it.
Okay, so quite a few causes for lower extremity swelling. The most common that we see and that we encounter is going to be venous disease, and that starts out basically with venous insufficiency. Every single person as we age, as you cross typically about a 60-year-old threshold or so, there are one-way valves in your veins, as opposed to your arteries that are delivering blood flow from the heart out to your tissues. Your veins are returning that blood flow back up to your heart, and they're doing that typically against gravity. The arteries have smooth muscle built into that to help to kind of pump that blood flow all the way out. The veins don't have that same luxury. They rely on all the muscles around there, as well as a series of one-way valves to keep that gradient kind of moving back up against gravity towards the heart. And those valves eventually become a little bit leaky. And so gravity starts to win that battle. We start to see typically the varicose veins, the different types of spider veins and things like that. It can also be swelling. It can be increased pressure. Anytime you're seeing swelling, resulting in the foot or ankle, by that point, it's already progressed to a point where you do have a lot of increased pressure inside of that foot. Certainly if you see that, a good kind of first line to try is just kind of your over-the-counter compression socks. And those are things, again, you can get at a Walgreens, at a Walmart. Any drugstore should have kind of these over the counter. The reason I suggest that as a first line is just to notice if you are having any improvement with that. A lot of times that is showing up as fatigue, both kind of as you're walking around, but specifically towards the end of the day, fatigue in your legs, swelling, sometimes even nerve pains being related to that swelling. Other reasons, let me rewind. So as far as that venous disease would be the concern, then it's additional testing. It's usually referral to a vein specialist to determine if the veins are inadequately returning that blood flow against gravity, then, sometimes the prescription compression stocks, sometimes procedures to actually ablate or scar down the veins that are not working well. Other reasons we can see swelling in the foot, obviously any kind of inflammation or pain, infection, injury, those types of things. We see, with particular cardiovascular disease, as well as pulmonary conditions, COPD, emphysema, those all creating kind of an increase in pressure up here, driving more blood flow, typically corresponding with a higher blood pressure. And more blood flow down, but not the same pressure driving things back up. I would say that those are the most common things that we deal with, both the vein side of things, as well as some of the heart disease, heart failure, COPD, and other pulmonary conditions.
What about wearing Birkenstock sandals?
For most people, I don't have an issue with that. I try to be very practical, particularly with my patients, that I want people to be able to wear what they're comfortable with. I know that it does not always make sense for people to be in closed-toed shoes, and when possible, I want people to be able to do that, especially, being kind of new to Lawrence and being new to Kansas. It gets hot out here. Birkenstocks are a pretty darn good option compared to a lot of the other shoes that we, encounter, the other sandals and flip-flops. Certainly there are other specialty brands that, provide a lot of support. They have arches built into them. Birkenstocks, being that they are typically, a cork sole on there, they typically have a pretty decent arch support. Most patients, with a good arch are going to benefit from that. I say most, I would recommend against anybody with a history of wounds or ulcers on their feet, because that can be sometimes too much pressure in areas that we are otherwise wanting to offload. Certainly flat foot deformities and some of those things can, increase pressure where, if you have a rigid flat foot and we're trying to jam something with a pretty defined arch underneath, that can be too much sometimes.
Other questions?
All right, thank you all for attending. Thank you, doctor. We really appreciate it. And thank you, Allison. I will end this by saying I know we had some technical difficulties, particularly with the projection, not
Okay.
anything to do with you, that we will work out. We took note of a lot of the people had some trouble hearing and some other issues. We had a recording problem. We'll straighten those things out as we go forward. And I consult with the technical people who really know what they're doing. So thank you all for coming, and I appreciate it. And we'll see you at the next event you guys attend. Thank you.
Thank you, everybody. There are a bunch of, free swag in the back, different types of, ice packs, pens, business cards, different